The Tuskegee Syphilis Study, formerly titled the Tuskegee Study of Untreated Syphilis in the Negro Male, was a 40-year clinical study conducted by the U.S. Public Health Service beginning in 1932 and ending in 1972. The stated aim was to observe the natural history of untreated syphilis, but the study became infamous because hundreds of African American men who had the disease were never given adequate treatment and were misled about the nature of the research. The study enrolled 600 impoverished black men from Macon County, Alabama, 399 diagnosed with latent syphilis, and 201 without the disease as controls. Participants were told they were being treated for bad blood, a local term that encompassed several ailments, and were offered free medical exams, meals, and burial insurance as incentives for participation. Researchers deliberately withheld effective therapy from infected participants even after penicillin became the accepted and widely available treatment for syphilis in the mid-1940s. While penicillin was established as the standard of care by about 1947, those in the Tuskegee study did not receive it. Instead, some men were given ineffective or placebo treatments and subjected to invasive diagnostic procedures presented as therapy. The ethical failures of the study were manifold. Participants were not given informed consent in any meaningful sense. They were deceived about their diagnoses and the purpose of the procedures they underwent, and researchers prioritized long-term data collection over the well-being and lives of vulnerable human beings. These violations betrayed both basic human rights and emerging standards of medical ethics that stress voluntary informed consent and beneficence. The human cost was severe. By the time the study was exposed and terminated in 1972, many participants had progressed to tertiary syphilis, resulting in deaths, debilitating illness, and transmission to wives and children. Investigations and later settlements documented that dozens of men died directly from syphilis or related complications. Many wives were infected, and children were born with congenital syphilis. Public revelation of the Tuskegee study in 1972 prompted immediate outrage, congressional inquiry, and institutional reforms. An ad hoc advisory panel reviewed the program and concluded it was ethically unjustified. The study was halted. Survivors and their families received medical and health benefits through programs established afterward, and a class action settlement was reached in the mid-1970s. The scandal had enduring effects on medical research policy and public trust. It helped catalyze stronger federal regulations governing human subject research, including the development of institutional review boards, IRBs, stricter informed consent requirements, and the Belmont Report's principles of respect for persons, beneficence, and justice. Principles designed to prevent exploitation of vulnerable populations in research. Beyond formal policy, Tuskegee left a deep scar in African American communities' trust toward medical institutions and public health authorities. The study became a potent symbol of racial injustice in medicine and contributed to long-standing suspicion that continues to influence healthcare-seeking behavior, clinical trial participation, and public health outreach among minority communities. Remembering Tuskegee is not merely an exercise in historical accounting, it is a moral imperative. The lessons of the study, to center informed consent, protect vulnerable populations, and hold researchers and institutions accountable, remain vital safeguards. Acknowledging and addressing the harms done, including formal apologies and reparative programs, are necessary steps toward rebuilding trust and ensuring that research serves the health and dignity of all people. The Tuskegee Syphilis Study stands as one of the darkest chapters in American medical history, a cautionary tale about how scientific authority, institutional racism, and neglect of ethical duty can converge to harm human lives. Its memory must continue to shape how researchers, clinicians, regulators, and communities collaborate so that medicine honors both scientific inquiry and human rights.